Everyone hear me okay?
Yes.
All right, good afternoon, everybody. Welcome to office hours. Can you see the slide deck all right?
Yep.
Great. All right. Well, welcome to February office hours. And as usual, we got this recording for folks and will be up on the website in the near future. And we'll have opportunity for folks to ask questions along the way as usual. And if you want to put things in the chat along the way, please feel free. Sorry about that. I just put things back off the screen. Is it back up on screen for folks to see? Sorry. Just
Yep.
did it again. I'm trying to get people into the meeting and I just took the slide deck off. I'm sorry. Pop that back up here. Here we go. Is it back up?
Yep.
All right, perfect. So folks want to ask questions on the way, feel free, and we'll do that. But with that, we'll get going. We're going to go through some redesignation items today from our children's redesignation last fall. We're going to touch on those periodically over the next few months as things come through on our next couple office hours. We're going to touch on that manual signature plan of care update that just came through last week. We're going to talk about the plan of care compliance audit, where we're at with that. And then we're going to do the 25 Health Home Network audit results, how we did as a network overall, just some highlights for the children's and adults for the programs, some children's updates, and then just some program updates and reminders in general. So just to start off, I just wanted to touch on, we had some policy things that we had in general, just from the redesignation from Children's Review. These aren't annual updates at this point for policy touching. This is more of the results from the enhanced oversight plan from Children's Redesignation. Oh, you got somebody on unmuted. So these were themes that came up that we had to do an enhanced oversight plan on as a lead that came out of the redesignation. So see, these are items that I'm going to touch on in the next couple of slides that were. Oh, we got some folks talking. Are we good? All right. So we got on areas on the enhanced oversight plan where we didn't meet 90% criteria or better, that we had to do an enhanced oversight plan on domain 3. So these particular topics that I'm going to touch on were those areas. So we had to do a corrective oversight plan on those. And this particular policy for continuity of care and re-engagement for enrolled health home members, these particular topics were those points that we have to, as a network, have a little more oversight to improve upon. So ensuring there was documentation in the person's chart of the care manager and initiating diligent efforts to attempt to locate the members. We got in as a network, just make sure that we're looking at that we're documenting those efforts and the chart a little bit better. So just so as we're out there doing our work, that we're making sure we're documenting those efforts in our charts, and then ensuring documentation that there was evidence that the care managers determined that the person disengaged from services when that is in fact the case. So again, part of policy, state identified that there was a theme that wasn't occurring. So that was an area that they marked off for us as a network. Didn't know if there's any questions on those particular areas that anybody had that they wanted to talk about. Next topic was around incident reporting. As a network, we got knocked on the fact that we weren't within 24 hours of identifying, being made aware of an incident, getting that reported to the health home. So we just want to make sure that we're doing our due diligence and doing that as we become aware of an incident within 24 hours, getting that reported in and through to the health home. So I know we work hard to do that, but again, we can continue to push those efforts as best as possible. Any questions on that? Anything anybody wanted to bring forward there? Pretty straightforward, but an area they felt that we needed to improve on.
Hi, Travis. Can I ask a question about your slide just before this one?
Yeah,
This is Christy.
sure.
The second piece here, ensuring there was documentation in the members chart indicating there was evidence that the care manager. Can you explain that a little bit, like clarify that for me? For some reason, I'm struggling understanding that one a bit.
So if there wasn't any engagement, just making it clear that there was efforts that the person hasn't been engaged in services, that you've shown your due diligence to try and engage with them, and they're just not engaging, and that's documented in the chart, that it's clear that that's been the case. Just showing that you've made your efforts and that they've shown lack of engagement.
Okay, gotcha. Thank you.
Yep. Any other questions on that? Transfer policy. This is an area that Department of Health felt that we didn't feel that the record contained, there was transition to the member to an adult service provider. So we have to make sure that there's documentation, that there's indication that there was discussion of that transition to the adult service provider occurring. So an area that we have to, as a network, improve on further. So just note that as you're out there doing your due diligence, which I know we all are, that's an area that the Department of Health feels that we have to improve on as a network. Any questions on this particular one?
Travis, this is Jessica Casey. Do you mean transition when we're transferring a patient from one CMA to another? When you're referring to adult service provider?
I would say adult service provider from children's to adult service provider, or just from one service provision to another. I would just say any transition from service provision from any service, I would make it clear, but in particular for this, to an adult service provider would be from children's to adults.
Okay, thank you.
Yep. I would say for clarity purposes, just make it very clear when you're transitioning from a service from one to another, what it is and what it's about. You just want to make it clear in the record. Is that helpful?
Yes, thank you.
Yep. Shelley, I saw you had a hand up. Does that answer?
We had a question just in general around transfers, not specifically for this situation that you're discussing.
Okay,
Do you want me to go ahead with it?
sure.
So we've run into situations where a member is transferred from CMA to CMA. So we were receiving a transfer and they met appropriateness criteria upon enrollment, but over time that appropriateness criteria has changed. And so when we go to enroll them receiving the transfer, enrolling them with us, they don't necessarily meet a criteria any longer, or we've struggled to find criteria that they meet. Any guidance, and then that could become a situation where the member, might get upset. Well, I was fine with the other agency. Why can't I enroll with you? Like that type of situation, we just want to avoid. Just didn't know if you guys had any guidance or other experiences with that.
So the appropriateness for services in general is what you're getting at now?
Yes. Yeah. So
Yeah.
the initial criteria, so they met it. So say
Right.
they've been enrolled for, quite a period of time and now they're transferring. That's a potential problem.
I think it's coming down to a discussion of their eligibility for services. I mean, and I mean, that's a discussion at that point, and that's a hard discussion. I mean, they have their process to grieve if they're not content with the discussion. I mean, if they're not eligible for the program, um,
Well, I guess what it comes down to is that it's not like, had they not initiated the transfer, they, that it wouldn't be questioned until, the CES tool.
sure. Sure. I guess it comes down to what types of things were they working on? What was the,
Sure.
yeah,
Okay. All
right.
right. Sounds good. Thanks.
Yeah. Any other questions? Or Jess, was there anything you had to add to that thought process?
Can you hear me?
Yes.
That I've only heard of this happening one other time. We had it with I believe it was a children's transfer. So there's only one other case of me actually hearing about this in that instance because they were actively enrolled with that CMA and then working with the CMA and then subsequently transferred to another. I believe that CMA and I connected to kind of figure out what would be the most appropriate, and then we just put a note in for the appropriateness criteria. When you guys do fill out your eligibility screens, they have that free text box at the bottom sometimes, and what you put in that text box does transfer over to DOH. So they do have that for reference. So if this does come up and you're not sure what to put, we could always work together to find something. Because if they are transferring from one CMA to another CMA, that should be allowable, except for in those circumstances where that CES tool says discharge, do not transfer them. But outside of that, service provision should continue between those two CMAs.
Yeah, I think the only other thing I would add is just as we're working with folks, we want to be mindful of the types of I mean, obviously the CES tool is really factoring into longevity of how people are in the program and how long, but the types of goals and services that people are working on within the program, we want to be really mindful of that. Are they appropriate and what are they really working on and what are their needs within the program? So if they're not really needing this service and they're just kind of hobbling along with one organization and then they go to transfer somewhere else because they're just not happy with the provider and they really didn't need it to begin with, and they go to the next organization and they're not truly eligible or appropriate, that could create an issue right out of the gate. So, just putting that out there. I mean, we'll always work and try and troubleshoot through a situation because we want to be able to support and serve the individual if they're truly appropriate for a service. But we also don't want to be in a situation if they're not, trying to come up with something when they're not really eligible or appropriate for it. That's a tough discussion to have with somebody. Hi, Andrea.
Yes, hi. I'm also getting a number of referrals that don't necessarily meet the criteria once I'm going to do the eligibility screening. Is it possible to add things to the referral? Because the referral, as it is, it's missing a lot of things in the eligibility screening. So when someone fills out the referral, 2 chronic conditions, perfect, lovely, send it over, but do you understand what I'm saying? Like there's things in the eligibility screening that aren't on the referral. So they might look good on paper, but when you go to do the eligibility screening, they actually don't qualify because they don't match.
That's happened to me as well. This is Jackie from case management at the hospital, but we've been in that situation before as well. It doesn't match. People just check whatever and then come to find out they're not eligible.
Yeah. So to look at the actual referral and have it
Or if we could put on the referral the items that are listed in the eligibility screening.
I
This
mean,
is
we can
Jessica.
absolutely, go ahead,
We
Jessica.
can we can revisit that. We had
Yeah.
discussed doing that in the past. However, as you have seen, the eligibility screening tool and those eligibility reasons have changed multiple times. So each time we would have to then update the referral form. And I'm sure all of you have seen that many folks use old versions of the referral form. But we can revisit this now that I believe those changes have settled down. Now that I've said it out loud, it absolutely will probably see a change. But it is something we talked about, but due to the rapid change in that criteria, that is something that we didn't do. But when anyone gets a referral, whatever is written on there, whether it be accurate, inaccurate, it is up to the accepting CMA and then that CMA who's enrolling that member you have to confirm eligibility and appropriateness. That's not on the onus of the referral source. That's on the accepting CMA to make sure that you are enrolling members who are eligible and appropriate.
Yeah, it just seems like the referral might be a touch misleading when you look at the difference between the appropriateness from the referral and then the appropriateness from the screening in NetSmart. And I don't know if anyone else would agree, but I would rather have an updated referral 50 times a year, but have it match what I actually have to do than, you know, scrambling at the last minute after I've already talked with the individual. But
Yeah.
I will take your advice and start checking that more thoroughly.
Yeah, we'll definitely take a look at the referral form again. And the other thing too, just to echo what Jessica's saying, if you're getting a referral that's incomplete, because that's been an issue in the past as well, you have every right as a provider to push that back to the referral source and ask for more complete information. Because if it's coming to you not completed, missing sections, that should not be happening. You should have as complete a document as possible. So just, you know, that's also something that as a recipient of the referral, you should be getting complete information as much as possible.
And Travis, this is Jackie again, you know, and that kind of reminds me of another point of the supporting documentation. So we're taking what the referent says at face value because we don't have the documentation to prove it.
True.
I can't hear you. I'm sorry.
Said that's true. Yes.
So, yeah, so, you know, you're not scrambling, but you have to get the supporting documentation, which the referent may not even have, especially if
Right.
it's like a school district or, yeah, okay, just making a point.
No, you're right. Yeah. Okay, we'll take that back. We'll take that, we'll look at the form and we'll see if we can make improvements. Thank you. Anything else on that stuff? Appreciate the feedback on it. All right. So disenrollment policy was the next area that DOH gave us an EOP on, and that was area on this was reviewing progress notes around billing sheet, so end reason codes for disenrollment, making sure that matches for folks when you disenroll. Another area was making sure the record contained a disenrollment letter that was written on agency letterhead. Another area through disenrollment policy was that the person's record contained DOH 5235 that was issued a minimum of 10 days prior to disenrolling on file for disenrollment that was not at the request of the member. And then also ensuring that the member's record contained the DOH 5235 with the name of DOH, with the name of the health home on it, excuse me. What we got, Tanya?
As far as the notice date being 10 days prior to the effective date, I thought we had to have 12 days to allow 2 days for USPS. Is that still not accurate?
Well, yeah, they
Okay.
said 10 days through their auditing, but yes, 12, please.
Okay, thank you.
Yep. They hit us for 10 days through their audit for what they do. But that's what we have for policy on our policy, the 12. Anything on the disenrollment policy otherwise? Other questions?
Yes, hi, Addie Atchison, People USA. Could I just get a fillable version of the disenrollment summary?
The disenrollment summary, Addie?
Yes. The one where it says like mental health, physical health, substance use, where you'd be able to write persons like next appointment dates, their providers. I believe in the original disenrollment and graduation training, I think it was Jessica that shared as on one of the slides, just a small version of it. Just wondering if you happen to have that.
Yeah, so we do have an example and we have an example in our policy, but the only
Okay.
version that we have that is fillable is our actual version that our internal care management team
I
uses.
see.
If Addie, if you want to send me a separate email, I
Okay.
will see if I can make modifications to that so we can get you one.
Sure thing. All right. Thank you.
Any other questions around the disenrollment points that were brought forward on the EOP for DOH? All right, there'll be some other areas that'll come up in the next couple months that we'll touch on, but those were for what we said we would do for the month of February for our EOP. So with that, I think I'm turning it over to Jessica for the next set of slides here.
Yep,
Jessica?
I'm here. Can you hear me?
Yep.
Okay, everyone bear with me. I'm not feeling wonderful. So I just wanted to briefly kind of go over our redesignation findings as they relate to the chart audits that we had for our children's redesignation. So again, everything that I'm going to review is specific to our children's redesignation. So they pulled 55 records for redesignation. They reviewed 50 of those 55 records. They pulled those records across 10 different CMAs. Some CMAs had only one record pulled. Some had as many as 16 records pulled. One CMA actually did not have any pulled, and they are an established CMA that we have had for since the inception of Health Home. Our larger ones, we did see a little bit, obviously a higher census pulled from them, but really there was no rhyme or reason to the sampling. And then to the right, there is a picture that kind of shows how we scored on each domain of the audit. So I know everyone wants like specific feedback related to their individual CMA. The way that we are audited it's not easy for us to give you a raw score because that's not how they score each audit. It's not like we do our internal audits. They kind of score everyone at one thing and then they go over each individual domain. So from this, you can see what areas that they scored us on, which were eligibility and appropriate, required forms, assessments, service chart, plan of care, care coordination, and disenrollment. And then you'll see in parentheses, and that will show you how much that section was weighted. So we have a raw score and then we have a weighted score. So like eligibility and appropriateness, that counted for 21% of our score. So we did very well in our areas of eligibility and appropriateness, making sure our required forms were on file. Our chart, so that's service chart, is basically what is the care manager doing. Our assessments did good. Our plans of care were at 89%. We did pretty decent there. And then the area of concern on their end was the care coordination, and then disenrollment at 88%. So those are kind of the areas of focus, because we do want to make sure that we're staying pretty high in our percentages, which this kind of aligns with what we do see in our internal audits. So it was not shocking. But overall, we did pretty phenomenal. And they actually, and later on, I'll go over our internal auditing results for 2025. So in this instance, we were actually scored higher by the Department of Health for our audits than we show internally. So that was really good to see. You can go to the next slide. Next is just going to be a couple of comments that the Department of Health left on our audits. Not every single audit, actually most of them did not have any comments. But just a couple of comments. And one of the records was that eligibility and appropriateness was really easily located. They went right to the children's eligibility screen. Care manager did a great job of obtaining and uploading proof of SED. Member was referred and linked to HCBS services. Medicaid was verified monthly. They found that in the children's billing questionnaire, the care manager did a good job with care coordination with the member, the parent, the care team. They had several interdisciplinary team meetings. The care manager did not address the HIV/STI risk with the member, despite the caregiver's concern. So that's one of the things that they were looking for that they didn't see. And that the care manager did document barriers to accessing care. I'm not going to read through all of this. The next comment that shows that the record that the member was made aware who their assigned care manager was, how to contact their care manager, did a good job of documenting strengths in the comprehensive assessment / CANS, carrying that over into the plan of care. The plan of care was written in person-centered language, which included strengths from the CANS assessment. So really overall, when they did write notes, they documented some really positive things. And they did point out a few records that really went above and beyond during our exit conference. Does anyone have any questions on those two slides before I get into kind of the findings and the areas of improvement? Okay, you can go to the next slide. So Travis just went over some of the things that are on our EOP. We are going to be sprinkling those things in throughout the next 6 months. We're not going to hit everybody up with this is everything that needs to be improved upon right now. But a lot of these things are things that we talk about all the time. There are a lot of things that we also find in our own audit. So this is what they kind of noted for our EOP and things that they pointed out to us that they would like for us to focus on in the future. One of those things being gap in care monitoring and follow-up. That's kind of a semi-new feature that we have in NetSmarts. We really want to make sure that we are following up on those open gaps in care. Our care transition follow-up. So anytime there's a HCSNI alert, an ED visit inpatient, we want to make sure that we're following up with our members. We're following up with the facility. We're making sure that that member has a smooth discharge back home. The one thing that we did get dinged pretty hard on was ensuring that if we do have a member who may meet the risk factors for HCBS, that we are discussing HCBS with the family. They saw a lot of us identifying CFTSS services, HBCI services, but the one thing was lacking was presenting HCBS to the family. So they really want us to make sure that we're presenting that to any of our families who may meet those risk factors and that target population. One thing that's been an area of topic for a long time is making sure that you are reviewing that FAQ document with the family at intake prior to them signing consent forms. I'm sure you're all doing it. It's just making sure that we have the documentation that you guys actually reviewed that FAQ form. So a lot of you are now putting that right in your enrollment note that you reviewed the FAQ with the family. So I'd really like to see that moving forward because it is really concrete that that was reviewed. Paul, do you have a question?
Just a question / comment. Can you hear me?
Yeah.
So related to HCBS and the discussion of that with risk factors, any discussion about the necessity of that now with the inception of RAP? So what we find is that we're discussing RAP with people more frequently because quite honestly, that does a heck of a lot more good for anyone than HCBS. And you know, in the days of a workforce shortage, when agencies are sharing providers between their CFTSS program and their HCBS program, the tendency is to pick the one that's going to make the most headway for the child and family, which is typically the CFTSS array of service, not something like respite. So if you have a choice between CPST and respite, the reality is that we're picking we're picking CPST for the family because that's going to be the service that's going to benefit the child and family the most, and straying away from things like respite. So how does RAP play into the HCBS discussion?
Yeah, so two comments there. So you're correct. If you are, having the discussion or the thought process that you're sitting there, you've identified that this person may meet the risk factors for HCBS. Also, CFTSS comes into play. What is the most appropriate service for that member? You just kind of internally had that discussion with yourself saying like this person would benefit more from a CPST service over this service. So that's why we're going to go with this service. It's really documenting that conversation that you just had with yourself kind of happened also with the family and that you're documenting that in the record. So that's all that they're looking for is that you have this person that may need and meet the HCBS level of care, but you're going to pursue at this time a different level of intervention. And then what your reasoning is, that doesn't close the door on the higher level of intervention. It's just not the most appropriate avenue at that time. So what they're not seeing is just kind of that conversation in the record, but that doesn't mean that your professional judgment is wrong at all. And no one would disagree with you on that. As far as the high fidelity RAP piece goes, so that is difficult. It's much easier for our folks who are in Essex County because there is high fidelity RAP available in Essex County. That is not the case for most of the counties that we serve. So it cannot even be an offered service in most of the counties. However, if high fidelity RAP is an offered service in your county, and that kiddo comes out as eligible through your assessment, then you are obligated always to have that conversation about high fidelity RAP. So that's another service that if the service is available and that kiddo is eligible, you 100% of the time do have to have that conversation. So in Essex County, you are a tiny county that does have a robust number of services. So you would offer that full service array and then using your professional judgment and working with the family as to what would be the best fit for them. And a kiddo can be in high fidelity RAP and receiving other services at the same time. Does that help?
Thank you. It does. It does. I wasn't sure if they were looking for the pursuit of HCBS or just the discussion about.
Just the discussion. Yep. So that's
Perfect.
a perfect example that you gave is just kind of that discussion. So I'm sure that discussion happened. It was just not memorialized in a note. So then inherently we kind of get dinged for that because if it's not written down, it didn't happen.
Understood.
Yep. That's a great question.
Thanks.
Okay, so moving on. So the next thing that they were looking at and kind of noticed is that ensuring that the contacts per the member's acuity are occurring. And if they didn't occur, is there documentation why? So there was a number of records that they reviewed that they found where this youth was required to have 3 core services, 2 face-to-face. And for whatever reason, that didn't happen. And that care manager billed down, which is totally appropriate. But why didn't the contacts happen at that increased level of acuity? So that's what they're looking for. So if you cannot meet the minimum core service requirements per that member's acuity, is there documentation in your record as to why they were not met? One of the things that we've worked really, really hard on is making sure that those needs that we're identifying through our assessment, so your safety and crisis plan, your CANS assessment, potentially your HCBS level of care if you have one, any of those needs that you're identifying in those assessments, are those pulling over to your plan of care? Then what is the care manager doing? And then what is the follow-up? So really it's kind of three parts. One, identifying the need in an assessment. Two, putting it in your plan of care. And then three, acting upon that need. So they look at it in kind of three parts. We did an amazing job at identifying the need. We did a really good job in the area of putting it into our plan of care. That is a great improvement. The last piece though is when they reviewed our care manager notes, they didn't see a ton of action on a lot of those needs. So, you work monthly with your members, you tend to address other things more frequently than you would. Some things were getting left behind, and they were finding that months and months and months would go by without anything happening to that objective or intervention in the plan of care. But overall, we scored really well in this area, but unfortunately, it was an area that they did ding us on. We do have a question from Paul, says that we're finding in general, many families don't see the need for a second in-person visit. Sometimes getting that visit in to bill at high is like pulling teeth. Paul, yes, that's not uncommon. Excuse me. If they're refusing that second in-person visit, they find it too intrusive, they don't have time for it, that's where you can offer that telehealth visit, and that telehealth can happen in lieu of that second face-to-face, and that's okay. And that's not what we were dinged on. It's just blatantly kind of the care manager did not document why that visit did not happen. So you can absolutely utilize telehealth, or you can document that the family was less than engaged. That's why that didn't happen. That's all appropriate, and you would not get dinged on an audit for that. It's really when there was kind of like blatant, there's no documentation as to why the services weren't delivered. Travis went over this a little bit today with our EOP earlier, making sure that we're disenrolling folks. We're using the correct end reason code for disenrollment, that we're issuing the disenrollment letter on agency letterhead, and we're issuing that 5235 10 days prior to discharge. So we went over that a little bit, but this is kind of the highlights of redesignation. And then later I will review our 2025 audit findings for adults and children.
All right, thank you, Jessica. All right, so we had last week the manual signature plan of care capture date went into effect. Just wanted to reiterate that is now up and running. I know that folks started using this new feature, and I just want to take some time just to reiterate that it's out there and happening. Obviously, the electronic format is the ideal way to capture plans of care. So electronically, we'd like to see folks have the signatures if at all possible. But obviously, manual is an option, and often that is the way that we do obtain signatures for individuals. And if that is the case, there is an option to capture that now. So we want folks to be able to utilize that option if possible, and we want to make sure if you do that you're following these steps that are outlined, and save it in the function and print off, and you're gonna go out and get that wet signature, and you're going to save it within the care manager plan now. It's not going to be in the documents tab. It's going to be in the care manager plan. So we got to make sure that we're doing that. And then you're going to have a new attachment section. Once you click on new plan and amendment, then there's going to be a new attachments tab that's going to show up, which is going to allow you to start to upload into the new feature. And that date completed date is going to be the actual date that the member signed the plan of care, because that's going to be the date that's going to synchronize with the electronic date, excuse me, that's going to be sent to MAP. So that's going to be the finalized date that's going to go to MAP. So we got to make sure that that's matching. So that's why that's so important. So I just wanted to pause and make sure there wasn't any questions on that, or if anybody had any comments around that. So
Travis, we
that's
do
good to
have
hear.
one in the chat from Allison. She said, if requiring a wet signature, what is the deadline? I'm not sure what you mean by what is the deadline on that.
So for example, say that I get a plan done for them or like today, for example, what's the deadline after that to get a wet signature? Because I know before that was part of the problem was that we were taking like too long.
Okay, so yeah, so now that we have this new feature, that's a great question. So now that we have this new feature, as you can see on slide 12, once you have that plan of care and you go to obtain a wet ink signature, that's going to be when you obtain it. Obviously, you want to obtain it as soon as possible because you will then put the date that it was actually signed where it's highlighted date completed here. The longer you take to get that signature and input a date in here, the longer that plan of care is not billable. So as Paul is trying to clarify, it is not official and billable until it is signed, and that is correct. So that's either going to be the electronic signature date or the date that is input in this highlighted section.
Any other questions?
Yeah, it's Sarah. I just wanted to ask a question. So we have gotten a few referrals recently, people mostly coming out of an inpatient setting who are more stable than they were when they went in, but not completely stable and have quickly destabilized, and they are not signing. They're sort of disengaging pretty quickly after discharge from inpatient, and they're not signing the plan of care because they're high risk. I'm not necessarily, we're trying to keep them active. We want to make efforts to try to re-engage them or see them through, because they're likely going to be rehospitalized. In the meantime, we're documenting that in the notes. We can't bill, obviously, because it's not signed, but is there something else that you want us to do?
I think your documentation in the notes is the only thing you can do. I mean, unfortunately, if the plan's not signed, it's going to preclude your ability to bill if there's not an electronic signature by the member.
And we've written on, I think there's two of them now, client, not willing to sign at this time, and we've uploaded it just to say that it's there, but we're obviously not billing. So
Right.
Is that okay?
Well, I think you're showing your efforts that you're doing what you can, but
Okay.
the bottom line is that in order for the person to be billable, they have to sign the plan. It's not a court-ordered situation for them, right?
Correct.
Right. So you have a circumstance where it's voluntary, and in order for them to sign off voluntary, in order for you to bill, and they're not willing to do that, you're not in a billable situation. So now you're providing a service and you're not billing.
It's certainly not ideal.
Yeah. Yeah.
And we've been trying to talk to the hospital a little bit more about that, but yeah. Okay, I just wanted to make sure I wasn't missing anything else you wanted us to do.
I think you're documenting and you're showing your efforts. I don't see anything else you can do outside of that. I mean, you can't force the person's hand, obviously.
Right.
So
Okay.
I don't see
Thank you.
anything. Yeah. Jessica, anything you're thinking of? I don't think of anything else.
No, the only thing I can think of, Sarah, if it's at all possible to get any type of initial plan of care at that initial intake with the member and get a signature on it, and then just put a note in that it's like a bare bones plan of care that will be updated to a more comprehensive version, but this way you're kind of covered for billing. I don't know if that's possible in these circumstances, but that would be my only other thing I can think of.
Yeah, yeah, I do want to strategize a little bit about how to do that when we get these guys that are kind of in this window. Because we usually sign them on, and do the warm handoff while they're still on the unit. We're not usually doing the comprehensive assessment at that point. But yeah, I do want to, if I think this is going to happen again, because it's happened twice recently, I do want to look at it a little bit differently.
Yeah,
Thank you.
that's a tough one. Jeez. Well, good
Yeah.
luck with it.
Thanks.
Yeah.
We do have
I
a
saw
couple
another
comments.
question. Yeah, I saw
Oh, can you
another.
see him, Travis?
I see hands. I can't see comments unfortunately because I have a
Okay.
full slide deck up.
Okay,
in
so I'll go to the
presentation
comments
mode.
first, and then we can go to the hands.
Okay.
So Rachel is asking, are we still printing the plan of care and draft to obtain the signature and then finalizing it, or are we now saving it final first and then getting the signature? That is the second one, Rachel. You're going to complete the plan of care, and now when you select manual, that is when you're going to be able to upload the signed copy. So now when you finalize it with a manual signature, that date does not go to MAP. It will not go to MAP until you input the date that the plan of care was actually signed with wet ink. Then Beth is saying, I'm not seeing the attachment tab under care manager plan. I thought it was supposed to be there. It is there. You do have to start the amendment. It doesn't show until you start your plan of care. So you have to go in and actually start your plan of care to have that tab generate. And then someone saying, I'm also not seeing it in the attachments tab. I haven't seen it yet in either in NetSmart. Yes, you have to go in and actually start your plan of care and then it will appear. It just doesn't appear. Beth is okay, Beth, I'm not sure if you're having a one-off issue because we have not heard anyone not being able to pull it up. But we can, if you email me, we can set up a screen share and I can troubleshoot that. If there's something truly wrong, I will have to put a ticket in with NetSmart.
Yeah, we can reach out. We've been meeting with NetSmart pretty frequently on some other things, so we can absolutely follow up quickly with them.
Okay, you can go to the raised hands. That's all the chat.
Let's see. Oh no, I just lost my sharing. So it was Christy? Was the first hand, I believe.
Hi, thank you.
Yes.
I apologize in advance. I tend to be a little slow on the uptake. So, I just want to make sure that I'm really clear on this process with plan of care signatures. Okay. So before, we were having CCs print out, keep the plan of care in draft, print it, because they're going to visit that client that day, get a wet signature, bring it back, finalize the actual plan of care in NetSmart, and then upload the draft with the wet signature in documents. That's what we were doing before. So I want to make sure that I'm clear now. Now they have to, if they have to get a wet signature, they need to print out the finalized, not draft, a finalized copy of the plan of care to bring to the client and have them sign the finalized copy. Am I right?
Yes, they have to select that the client reviewed plan, and then you're going to select manual signature and then save that. And then you'll be able to go in and add the attachment.
Okay, thank you very much.
So that is a change. So yes, the way
Okay.
you were doing it was what we had implemented in the meantime. So that is correct.
Okay,
Now,
perfect. Thank
now
you
that
so
we have
much.
the new feature, you're going to move forward with the new process.
Now this
Got it.
So you
this
got
new
it. Yep.
this new feature won't let the finalized upload that date to MAP though until this attachment's finally uploaded, etc. So that it doesn't complete that process like it used to. When you clicked finalize before, it would automatically send that date to MAP. It doesn't do that now until this attachment process is completed.
Okay.
So there's kind of it's a safety feature in there now, if you want to call it that, until this attachment is uploaded and then processed.
Okay, that helps. Thank you so
Yeah.
much.
Yeah. And I believe Raquel, I think you were the other hand up.
Yeah, so I did 2 care plans right before you guys had this upload thing in the section for the care plan. So I uploaded it to documents. Do I need to go back and upload it to the care plan section now?
Was it right before the go live date?
Honestly,
Like-
Travis, I have no idea because I feel like it changes hourly.
Oh, gosh.
So I don't know. I don't know. I mean,
The
I
go
didn't
live
see
date
it there,
was
but
Wednesday night. The
it was the
28th.
18th.
The 28th?
All right, so if it
18th?
was after the 18th, then I need to go back and put it in
Yeah, it was
the
the
care plan
18th.
sec.
Yeah, the 18th, I'm sorry. We're not to the 28th yet, yeah.
And I'm still confused because now you're saying that we need to have the care plan finalized to bring it to them to sign. I thought the whole point was we weren't able to finalize it until we had a signature.
That was
So that was correct. I can hop into UAT and share my screen. So we can kind of walk through it if that would be helpful. If you want to stop sharing, Travis.
Will that help folks to see that?
Yes.
All right, let's do that then. I'm gonna stop sharing. Yeah, the way it was before this feature was put in place, if you finalized it in production with that electronic signature would automatically go right up to MAP, and that was what the issue was. And if you didn't have a manual signature or plan uploaded in the system didn't know that, so it would just go off the electronic signature date that was finalized. So that was a problem because there was a lot of plans of care that weren't uploaded, or if there was one and there wasn't a signature in there, or there was various things that were going on. So that was causing a lot of problems. So this new feature that's putting in now, you're allowed to finalize the plan, but it won't upload that final signature date until the plan's actually up and attached, and then that date signed is entered into that attachment, which Jessica will show you as she goes through this. And then once that's in and attached, then the whole date syncs and goes in, and then it finalizes fully. I'll shut up so Jessica can show you.
Yeah, can you see this?
Yes.
Okay, so this is in UAT. So I just started an amendment. Everything is here. Great. Pretend this is a full wonderful plan of care. So now what you're going to do, say I am not with this person or I'm with this person and they cannot electronically sign because, I don't know, the Wi-Fi is terrible, something's not working. Before, this is where you would stop, print it in this draft status. But now that we have this new feature, you can click Client Reviewed Plan. And then, of course, my computer's going to be slow. Then you're going to go down and you're going to click Manual. You can do whatever. You're the care manager. And then you hit Save. So now, yes, this is showing a finalized plan of care, but because it's a manual signature, nothing is generating to MAP. This plan of care is not going to pull to MAP. Now what you have to do, you're going to go out and you're going to get your wet ink signature, your DocuSign as soon as possible, because we want to make sure that this is a billable plan of care. So now you went on your merry way, you got it. Now you come back and you put new attachment. That's where you upload your file, and then that is where you input this date. So that's where you put this date that it was actually signed on, the date it was actually with the wet ink signature. And then you hit save. This is the date now that generates this plan of care to map. Now, as of whatever date you put in here, moving forward, this is a billable plan of care. So that is the new feature. The electronic signature works exactly the same way as it did before. So if you are going to do an amendment and you're going to have an electronic signature, you're going to follow the same exact process where you click review, the client has reviewed the plan. And then you're going to do mouse signing. This is so lovely. Save and close. Now that electronic signature date, now that's the date that goes to map. So those are the two ways that you can do this. So someone has a question for electronic signature. Since the plan of care is not going to be attached with the date completed entry, what date is sent to map? That's going to be the date that it is finalized. That electronic signature date is going to be the same date that it's finalized. So if I look at this plan of care and I open it, it's going to be this date right here. So if, say, I started this 4 days ago, this date right here, that is the date that goes up to MAP, marking this a billable plan of care. Other question is, can the draft be signed, uploaded, and finalized in the same day? Can the client sign the draft? That's not, it's not a fully finalized plan of care, so I would try to not do that. If you have rationale for that being your workflow, we are definitely open to discussion on that. But now with this new feature, you don't need to leave it in draft. It can be final, but if you have a reason that you are and it's justifiable, I don't see why we wouldn't allow that.
Jessica, I think it's Paul. I think the only justification for leaving it in draft is that if you were to go out to the family and something had to be changed.
Yeah, but you would know that. I think you would know that ahead of time, so you wouldn't really have a fully finalized plan of care in that instance.
Perhaps.
Yeah.
You know, I mean, I would think we've run into a couple instances where we've gone out with a paper version to get signed, and they were like, "Oh, by the way, you know, can we add this or
Yeah.
let's take this away?" And that gives you the freedom to come back and then edit the finalized thing or edit the draft thing, and then finalize it to match the paper document, so that you're not having to come back to a finalized plan and then create a new amendment and start the whole process over again. You know what I mean?
Yes. Yeah. So but that instant, so we were using that, like, only print it in draft and have it signed and then go back and finalize it because we did not have this new feature. So we're talking about fully finalized. This plan of care is good to go. If you still are going to have edits on your plan of care, then that's not a fully finalized signed plan of care. So this feature is for a fully finalized signed plan of care. So just like it would have been before, if you were going out to have it signed and then there were still edits being made, that's not a fully finalized signed plan of care. So we're talking about a plan of care that has been agreed upon all parties, that is inclusive of all of the needs that that family member may have.
Gotcha. Okay.
Shelly is asking just to make sure the plan start date does not need to be changed for electronic signatures. That is correct, Shelly. We go off of this right-hand side right here, this date right here that is finalized. That date, plan start date, does pull to MAP. It is in there. But you do not need to change this unless it is wildly out of compliance. If you started this plan, let's say 3 months ago and then you didn't get it finished because your person got arrested and they've been gone for 3 months and then they come back and you still have this plan of care going that's not yet finalized and it's sitting in draft, update the start date. But outside of very extreme circumstances, you're okay with your plan start date being a little bit off. So someone is saying, so we go back and finalize it before a wet signature. Yeah, so you're gonna hit that client has reviewed plan, hit save, and then now it's not official until you hit this attachment button and input that date. So it is not finalized, generating to map and billable until this date is input here for wet ink signature only. Michelle is asking, will there be problems with the start date and upload date being different? Nope. That is to be expected because you're getting a wet ink signature. So we know it's not going to probably happen on the same day. That's why it is a wet ink signature. Again, the faster you get that wet signature uploaded, the faster your plan of care is billable. So that would be the reason to expedite that process is something. And then something said, if something happened with the family canceled, then what? So if you have a planned visit with your family, you have your plan of care in here, you at your next visit, you're supposed to have it signed and uploaded, they cancel, then unfortunately your plan of care that you have in the system continues to be non-billable until you collect that signature. So that's why getting that signature piece is super important. Christy, you have a question?
Yes, so I was wondering if we have any kind of little grace period. So today there was a care manager that had, and this was before she isn't even aware of this new guidance. The care manager was kind of doing what our process was before, which is printing out a draft and having the client sign. I know she happened to meet with a client today for a visit, and she took a draft copy of the plan of care and got the wet signature on the draft. Can she go in and go ahead and finalize it and upload the
Yes.
draft copy with a signature just this time?
Yes, you can, if you have a plan of care in progress, you can come back and finalize it and then upload the wet ink signature. You can do that.
Okay, because right now all she has is the signed, is the draft plan of care.
That's
I mean, they
okay.
agreed on it, but it's in draft.
Yep, so you just want to have her come back and get that uploaded as soon as possible and then get it finalized so you can bill.
Okay, thank you.
Raquel, you have your hand raised?
So it was the 19th, of course, that I did those care plans. So I just went in and did the attachment and put the date that it was signed. So even though the sign date was the 19th and I attached it today, does it still count for the 19th?
So
As
the
long as it's that date?
19th, so the 19th is the date that it was signed. That is the
Yes.
date that is going to go to NetSmart saying that you have a signed plan of care.
Perfect.
If
Thank you.
it's, yes. You're welcome.
All right,
Any other, ready to move on, Travis?
I think so. Was that helpful
Okay.
for folks, that demonstration? It sounds like it was. Thank you, Jessica. Okay, so any plans that were in the old process that are in the route of getting finalized and finished up, get those in as soon as possible if you could. But we want folks getting into this new process as we're moving forward. All right, plan of care compliance audit concern. So I want to make everybody aware, we're halfway through our plan of care signatures, audits and our review, and we are going to be doing meetings with the CMA supervisors to review our results for those audits that have been completed. That would include potential self-disclosures. We're going to meet and discuss those results with those particular organizations, review the audit tool that we used, show the full transparency of what the details were for the review for those particular tools and review, look at the potential disclosure amounts. After the conclusion of that discussion with the organization, we're going to share the tool, give the opportunity for the organization to do their own audit, to review and validate our results from our review. And then from there, allow the organization to have a chance to have that validation. Ultimately, there's going to be a potential disclosure based on whatever the results were for that particular organization, depending on how they did through the review and the audit. So I just wanted folks to know that we are going to start reaching out to those organizations that have been completed. We are on a timeline from, as I had mentioned in our past meetings over the last handful of months, from DOH, from our redesignation specific to the plans of care, from the NetSmart compliance concern, not only for our health home, but that impacted a number of health homes. So we are addressing this particular area. We're moving forward on it. But in full transparency, these are next steps that we're taking. So I just wanted folks to be aware. So that is what's going to be occurring in the coming weeks. I don't know if anybody had any questions or anything they wanted to talk about around it, but just wanted to make that known. Okay, we'll be reaching out. Next thing is audit themes 2025. This is for the AHI audits that we did as a lead health home for health home serving adults and children for the network. Jessica, did you want me to do this or do you want to? I know you've been talking a lot in the last handful of slides, so.
Yeah, I can do it.
Okay.
So the next couple of slides are going to go over specifically our internal audits. So we did this at the end of last year. So we're going to wrap up. So we wrapped up 2024 last year, this year 2025. So I just think it's nice that we kind of like wrap up a year in review, and then you can kind of see where you compare to your peers. So these are our audit results for our health home serving children. So we have 11 CMAs for our health home serving children's team. So you can see the scores. Those are the blue line. Our average score that was across our 11 CMAs was an 83%. So that's going to be that green line. And then our benchmark is that 85% in that orange line. So you can kind of see where our network falls and then where you rank. So we had 5 CMAs that fell below the 85%. 3 were on target directly at 85%. 3 CMAs exceeded, and our top 2 CMAs scores were a 94 and a 96% on the children's side. So if you know what you got on your 2025 audit, you can kind of see where you fall on this graph. And then as you can see, based off of what we went over for redesignation, we performed better on redesignation on those audits than we did for 2025 auditing internally. You can go to the next slide. Next is our adults graph. We have 21 adult CMAs. The average score that on an adult audit was an 88%. 6 CMAs fell below that 85% benchmark. 15 CMAs, however, exceeded the benchmark, and our top 2 CMAs on our adult side were at a 95 and a 98% compliance on their scores. So again, if you know your results score that you got in 2025 for your adult audit, you can compare that to see kind of where you fell on this graph compared to everybody else. You can go to the next slide. So what were the themes? So what were the themes that we saw in our audits as we went through 2025? So what we saw on the adult side, were DOH forms, making sure those are completed correctly and uploaded in their entirety into the system, making sure that the problems you have listed are matching your supporting documentation. So do you have documentations that prove that the member meets the eligibility in those problems? Do you have signatures on your plan of care? Do your signature dates match? Making sure that you're following up with those ED visits, inpatient follow-ups, making sure that your care team is involved in your plan of care development. This is something that we do struggle with, that we do look for. If you don't have a very involved care team where there's not many people to reach out to or they're unresponsive, you can absolutely put a note in your record. This is much easier to do on the children's side because we tend to have a more robust involved care team on the children's side. But on the adult side, if you don't have that available to you, you can absolutely put a note in. Making sure that HARP and core services are discussed with our members, and we're completing that HARP, that HCBS core form in NetSmart, and then addressing those comprehensive assessment needs into our plan of care. So we discussed that a little bit earlier, that we've been really improving on identifying those needs through our assessments. We're doing a really good job of starting to carry those needs over into our plan of care. And then the next step is really to address those objectives and interventions for those needs. You can go to the next slide. So our themes that we saw in our 2025 audits for our kiddos. One of the things was the care manager not asking to meet alone to complete section 2. The 2 is left off of there on that 5201. You want to make sure that you are documenting that you attempted to meet alone or asked to meet alone with the youth to get section 2 completed. Refusal is absolutely allowed. You would just document that the FAQ was reviewed with the family. Making sure that your interdisciplinary team meetings are occurring at the frequency required, and that's according to that member's acuity. That your eligibility screen is matching your problems list, that's matching your supporting documentation. We really look for that golden thread. What makes that person eligible and appropriate for health home? That's what you're recording on your eligibility screen. Do those diagnoses match your problem list? Match what is uploaded into the member's record? And making sure that our signatures are on our plans of care. So some overlap with what the Department of Health also found. So that kind of wraps up 2025. We've started our 2026 audits. We will have some slight changes to our audit process in 2026. And we will be discussing our updated quality policy at March office hours. Does anybody have any questions related to 2025 internal auditing? Okay, go to the next slide. Next is our children's updates. So these are updates related only to our children's population. As many of you know, I've sent out numerous communications via email that Maximus is ending their contract as the independent entity for the end of March. So as of 4/1, the Department of Health, DOH, will now serve as our independent entity for CES. CES will still exist. The terminology for CES will still exist. It will just move to DOH versus Maximus. So anyone who is currently in the CES process, so if you have anybody that you've sent in or that you're aware of that has been sent in through SPOA, those are in the process of being completed and then sent to Health Home. Excuse me. All of those folks, so before you used to be able to choose, oh, I'm going to stay with CS, I'm going to opt out of health, I'm going to opt out of Health Home. That is no longer allowable. If you choose to be family of one to access HCBS care management services, you now have to be transferred to a Health Home. So folks that are in the process of gaining their family of one Medicaid, they are going to be transferred over to us, and that has to be completed by 4/1. And anyone who opted out of Health Home who has been sitting with CS, all of those transfers have to occur. We have noticed a slight uptick in transfers occurring because of that. very, very slight. And it really pertains to one county. So I'm not expecting a huge influx of referrals. So at the end of January, I did send out an email with all this information and all of the attachments, and notifications that were in there. So if anybody that sends a referral in for CS and that youth already has Medicaid, they're going to be turned around and then directly referred to the health home. So sometimes CS does get referrals for youth that already have Medicaid. They will no longer do anything with those. They're just going to stop them, and then they're going to send them right to the health home. If they do not have Medicaid, the DOH CS representative will work with the family for that family of one Medicaid. Once that's established, they will have to then transfer over to health home. You can go to the next slide. I have more on this. So moving forward, you're now going to submit an online referral for your non-Medicaid youth for CS. Before, it was that paper version of the referral that is no longer being accepted. You have to use this online portal to make your referral. I will be updating policy. However, the link directly to that referral, if you can see this is highlighted in blue, if you right click on the hyperlink, it will navigate you directly to that portal. So when Travis sends out these slides, please keep those for reference. It was also sent out in that email. The DOH team will review the referral that gets sent in. They'll contact the referral source and the family for next steps. If you encounter any issues with the CS process, I have no control over that. I can absolutely reach out to DOH, but these are the points of contact for CS at DOH. So you can email them or call them directly. Does anybody have any questions on that? Okay, go to the next slide. So this slide just kind of goes over a little graphic. I stole it from DOH. It kind of goes over the transition process. We're kind of like in limbo right now. CS really isn't accepting any referrals for family of one. They're trying to wrap up everything that they do have, and then now it will be going forward. OMH will have a role in the eligibility piece for this for family of one. That's not going to begin until April. DOH is heavily supporting Maximus right now. We're not sure if this is going to go under OMH or if this will stay with DOH with OMH involvement. Once I have more insight to that, I will let you know, but the process is not changing. You have to use that link to make that online referral. You can go to the next slide. Accompanied with this amendment and the removal of CES independent entity as Maximus, we also removed those DAHAB services from this new amendment. But I did just want to call out a couple of things that we're going to have. That transitional care coordination and transitional services are going to be added in this amendment. I do not think we'll have a huge uptick in referrals. We have not applied for the transitional care coordination component. It may change slightly how the referral workflow works. We won't know until that's in the works, if you say, but we have not applied to be that person. So that person in the counties that you serve will not be AHI. So once I know more information, I will let you know. That is basically transitional care coordination. If you're asking what is that, that is for very high risk, high need kiddos that are coming out of placement, that are at that transitional age youth. So it's hard when you're working between, there's still kiddos, but they still need adult information. Maybe there's no identified caregiver, maybe going home is not the best, but they're 17, 18, kind of how do we reintegrate them into the community and make them successful? It's very, very short term. They work with them, I believe, for only about 60 days, and then the handoff would go to health home. And then transitional services, those are some service dollars to help with that. And then for anybody who was thinking about maybe putting in as a service dog in your HCBS kiddos for adaptive assistive technology. That is no longer allowed. Not that we have any of those referrals in place, but in the future, if you thought about doing it, that is no longer an allowable service under adaptive and assistive technology. Does anybody have any questions on that? I will definitely have more information on the transitional care coordination and transitional services as it comes out, but I did want to give everyone a heads up. And again, this relates just to Children's Health Home. Okay, you can go to the next slide. All right, and finally, just some general updates and reminders. Just to make sure that your professional networks and your care coordination tab have at least one person listed in their professional network. We were on an email through our MAP IT subcommittee that this will go live in June with their new MAP update. So there's supposed to be an update to MAP in June. And this will be now a feature. So any plan of care that gets imported into MAP has to have at least one person listed on their professional network in order for that plan of care to upload successfully. So have your care managers start going in now. That gives them about 2 months just to, as they go in and work with their members over the next 2 months, just to see if they have one person listed on their professional network. If not, you can add at minimum at least one person to make sure that your plan of care does import into MAP. Does anyone have any questions on that? Okay, next, just a reminder that the internal HCBS DOH audit is in full swing. We did not have enough folks enrolled in HCBS to permit the Department of Health to come in and audit us. So they have asked us, so like, we're not going to come audit you, just audit all of your cases on your own and then give us all this information about your cases. So we are working through that. We have to, the timeline is coming up very quick. I have to have that wrapped up in the next 2 weeks. All active cases of January 1st, 2026 are being reviewed. However, if that member is currently active and they had more than one episode, all episodes will be audited. So we're auditing the member's full enrollment, not a specific episode. So if that member transferred amongst CMAs, even if that CMA A wasn't active as of 1/1/2026, they're still going to be audited because that member is still active in HCBS. So it's going to be, you may be getting an audit back that you did not expect because that person has, been discharged for quite some time. And then lastly, we have added a new sub-program called Pending Fair Hearing Aid to Continue. This is for health home use only. Do not add this program to your records. We will solely manage this sub-program. We will add it and remove it as needed. This will allow us to track our members that are in Pending Fair Hearing Aid to Continue. So if they have filled out their paperwork, they disagree with their discharge or their non-enrollment into health home, they have aid to continue. So they're actively receiving service. And we are waiting for a fair hearing. So the health home will be the one to add and remove this sub-program. We are using it for tracking purposes. So you will see that in there. Please do not add it to any of your records. Does anyone have any questions on that? Or anything on this slide? Okay, next, last but not least, we are still, going to have a care transitions training. I promise the deck is done. I do just have to get that scheduled, but we will be looking to get that scheduled soon, hopefully sometime in March. And that is the only upcoming training that we have. And that is it for me.
Thank you, Jessica. You still have a voice. A lot of talking today. Thank you for everything. Anybody have any questions? Anything they wanted to talk about that we didn't bring up today? Christy?
Just full of questions today. I noticed that when I upload documents in the Documents tab now, there's also a date completed box in there. And a couple of documents I uploaded, I felt I could assume, like for instance, a 50-55 or a consent for services, that date completed would be the date that the client signed that particular document. But as far as like uploading Hixney labs or medical records, should we be using as the date completed the date of, say, that the labs were done, or the date we uploaded the lab report? That makes sense.
Right. So we've had a lot of questions around this. First thing we wanted to mention is this came out unexpected to the health home. Somehow it got tied to that whole plan of care manual signature capture date feature. When that got pushed out by NetSmart, the date signature field also got tied to this attachments tab, and NetSmart didn't necessarily notify health homes about that. So when you all became aware of it, we also became aware of it as a lead. So when you were bringing it to our attention, we were becoming aware of it at the same time. So we looked into it as you were looking into it, bringing it to our attention. It can't be removed, unfortunately. So as you were bringing questions on the dates and asking us, and we were looking back into it, adding the date of entry, I know a lot of people are saying, well, the logic is time, date, and stamp. So what's the sense of putting the date of entry in there, right? Christie's point, you've got different dates on different documents that are coming in of when they were completed. Some are assessments that are done at certain dates. Some are assessments that are done by providers. Some are signed off by people, when they've completed the actual documents. So you got variations of dates of when they're coming in. So that was one of the reasons why we went with the date of upload, to make it simple. But what we're saying, when we came back and we sent the note out, I don't think it was yesterday. If you upload a date of completion based on a document that you feel when someone had signed off on, or you want to go with the date of upload, it's up to you. We're going to go by the date of time, date, and stamp, because that's what we're going to audit on. I don't know if that's helpful. We're going to give you the option of the date used, but we're going to audit based on the time, date, and stamp as the lead.
So the date that it is uploaded.
Yes.
Okay.
Does that help, folks?
Yeah,
So
yeah. So any document then that we upload into the Documents tab, that date completed section, we should use the date that we're uploading it, whatever the document is.
Well, we're going to give you that discretion.
Okay.
We're going to audit based on the date it was uploaded, though.
Okay.
Travis, is it a required field?
I'm sorry?
Like, can you just upload something and leave it blank? Like, is it a required field, or it's just there as a mechanism to...
They're put it in there and we have to fill it out. And we've tried to see if we get it removed, and it's for some reason, when they did this, when they put the manual signature capture feature in for the plan of care into NetSmart, when they built that feature, somehow it's tied into this attachment document tab as well. I don't know why, on the engineering side, and it's in there, and I don't know why.
Yeah, it's probably because it moves the upload from it doesn't move it, but it also duplicates it directly in the attachment.
Right. But it doesn't affect it. We have to upload through the plan of care for the document. That's the process. But if we enter documents through the document attachments tab, and we enter the dates we can enter whatever date we're auditing on the time, date, and stamp though, you know what I mean? So it's
Okay,
we have a different differentiation of what we can do there, but we can't remove that
sure.
field though. It's
Yeah, I
just
just haven't seen it
it's a
yet, so I wasn't
nuisance is
sure
what
if
it
it was a
is.
required field, or if it's something that we could just coach people to leave blank if you're uploading something that's
Right.
not a plan of care.
Yeah, it's a required field, but we have more room to what date we want to use. We have more room with it, but for auditing purposes, we're going to audit. We're going to audit on the time, date, and stamp though.
Gotcha. Thanks.
So
Yeah.
we can use our discretion on what date we use, depending on what we think is most appropriate, and whatever date we use, we won't get dinged, is what I,
Well, it's going to depend
Right.
on it's going to depend on the document you're uploading and the date that you use to upload it.
okay.
If that makes sense.
No, I'm a little unclear, but I don't want to keep people, but that's me, So,
So,
maybe
for-
we can revisit.
Yeah, I can just jump in. So, like, for example, if you're uploading, so the things that like we don't audit really the date and time that you upload things. We only look at that for like consent forms, for eligibility. So if you had a consent form, let's say you enrolled someone in December and they signed it on December 15th and you put the date in as December 15th, but you didn't upload it until today, you can put whatever date you want on there. I wouldn't suggest using December 15th, but we'll know that you tried, not that you would ever do this, not that anyone would ever do this, but you tried to like fudge the date so it looked like the document was in there on time. We're going to audit off of the time, date, and stamp that piece of paper was actually in the record. So like
Okay.
Health Home Plus documentation, let's say you got the documentation and it has a date on it from like November, but you never uploaded it. So when you go to upload it, you use the November date. That's great. I'm still going to look at the time, date, and stamp because you started billing in November, but you didn't add it till February. But like if it's, on the children's side, let's say you have like an IEP or you have like an evaluation of some kind and want to use the date of the evaluation, that's totally appropriate. We're only really going to look at it if it pertains to an audit point, and then we'll look at the time, date, and stamp. So we're going to leave it up to everyone's professional judgment as to what date that they put in that box.
Okay, thank you.
Of course.
Yeah. Well, it's like the plan of care. It's being required manually to be uploaded in the plan of care section now, so that the date is actually in there in the plan of care section, so we know it's uploaded in that document. And that's the date effective in that document now, and then that's what's uploaded effectively, right? In the document section, to what Jessica was just describing, if you uploaded a plan of care 8 months later, we would know that. You know what I mean? It'd be a huge discrepancy. So that's the type of stuff that we'd be able to audit and see the difference on. Hi, Amy. Oh, I think you're on mute still. I think you're still on mute.
Oh, she just put in the chat that she can't unmute herself. Amy, you can feel free to send us your question in writing and we can get you a response, or you can type it in the chat.
Anything else anybody had questions or anything you want to talk about? Well, thank you as always for everything that you all do each and every day. We really appreciate it. And I hope you all have a great rest of your day. Try and stay warm, and hopefully the snow goes away soon. Oh, did we have one more hand up or no?
No.
Amy? No, Amy's hand was up. That's what it was. Okay.
Oh.
All right. Well, take care, everybody. Thank you.